I'm talking about the Corneo paper that was up for this week's Journal Club.
Speak up, Brad. Speak up.
Up? Okay, sorry. It's echoing a lot. So it's a group from the Royal Melbourne Hospital that looked at a sort of three-group study of informed consent around knee arthroscopy. So that's come up really small, I'm sorry. Basically, before I got started on the article, I looked at what the RAC's policy was for informed consent. They've actually got a published guideline, which is quite detailed, but the punchline of it all is that they essentially want the patient to know about what their diagnosis is, what we're going to do to them, what could go wrong reasonably, if it goes wrong, what happens, how it could affect you, the significant long-term physical, emotional, or other outcome which may be associated with the proposed intervention, which apparently is normally poorly done, and time involved for recovery, which is different again, and expected costs involved, including out-of-pocket costs, which I, as a registrar, I've never spoken about to a patient ever. But that's essentially the summary version of what the RAC say should be in part of informed consent, which even this study didn't sort of encompass. Whoops, sorry. Okay, so the study itself. So the study acknowledged that the reason it's relevant is because as the field progresses, patients have higher and higher expectations of what we actually do, and they also have higher expectations of getting a very good outcome, and that as procedures become more complex, we have to constantly be revising what actually constitutes being fully informed. Obviously, there's a medico-legal implication in all this, in that it's very easy to be sued if something goes wrong and the patient wasn't aware of it. And there's one of the trials they mentioned, and two of the other papers in the MJA also mentioned, was the Rogers versus Wickett trial 92, where the judge ruled in favour of the patient because the doctor had a duty to warn a patient of material risk inherent in the proposed treatment. And that kind of underlines where we should be going with informed consent as far as these authors are concerned. The study basically said that the concern was that there's high variability in what we normally do, especially in terms of verbal consent, that what one doctor considers part of being informed, another doctor may consider irrelevant. So having a multimedia-based platform allows for a uniform amount of information and and provides a set amount of controlled information that's being delivered to the patient. And also noted that many of the informed consent models that are used, there's no sort of audit done on patient comprehension or recall in the choice of medium. Sorry. Okay. So the actual method was a randomized, non-blinded controlled trial. Although they were blinded, the researchers themselves were not involved in the consent process. There are three groups. They had a set amount of information that was either delivered by a verbal script, a written pamphlet, or a multimedia presentation that included text, voice, 3D models, and 2D visuals. They tried to make sure they had identical information across the various methods. They tried to do it 36 weeks before surgery, and then they had 2 time points. So 3 time points after that. They had immediately post-consent, immediately pre-op, and then 6 weeks post-op. And they had a uniform questionnaire with the same questions that was given to the patients repeatedly. Sorry. Okay. All right. Cool. So concerns with the study design. I think there was probably a selection bias that was pretty strong in this. They were using RMH patients only. They were sort of registering patients as this person should be for the trial, and it excluded those who had poor visual or poor sight or hearing, poor English, and I think those are 2 patient groups that would probably you'd be more concerned about them being consented well. So you're kind of excluding people that you probably want to consent more thoroughly. Anyway, the verbal consent was done by residents, not registrars. So, certainly for me as a resident, my knowledge of what I was doing was not nearly as good as it has been since I've actually started doing the surgery or assisting with the surgery. There was a lot of sort of candidate variability. The surgeons may or may not have seen the patient, they may or may not have been seen by a registrar, they may or may not have been seen first for this procedure, it may have been a follow-up or not. Anyhow, there were small numbers for each group, which the authors actually acknowledged. it was limited to they began the paper by talking about the complexity of procedures, then choose what is really one of our simplest procedures as their study base. And they only had a very baseline of reading in says mental competency. That sounds really bad, but essentially that how clever the patients were, and I didn't really know how to say that. But they had like an abbreviated mental score that they used, but it really didn't account very well for the degree of comprehension. I presume that they thought it was built into the score they got on the questionnaire. Anyway, moving on to the method. I won't go into like a stats breakdown, but basically they had parametric and non-parametric analysis, which is kind of saying that the data is conflicting within itself. But anyway, so they performed an ANOVA and a student t-test, and they performed a Crooksall-Wallace test, but they didn't actually say where they did what and which data they derived out of which test, which changes whether or not you can actually use it. But they didn't. They just said it was performed as appropriate. They said the power of the study was 0.8, so they limited it to the absolute minimum power for a valid study. They didn't actually state a null hypothesis, so you presume the null hypothesis was that multimedia was better than others. The differences between groups, they say themselves, they assumed a 5 to 10% variability rather than actually doing a sort of a priori analysis of their patient group. So again, it's a problem there. And the group sizes were calculated always working to the minimum number. So you're allowing for a lot of variability between your data, which is probably why they had to do parametric and non-parametric analysis. I presume one of them would have yielded non-significant results. Anyway, so yeah, there was no elucidation in which tests reported the results and where the significance came from. It wasn't clear whether they used ANOVA. They didn't, so about why they used a Crooksall-Wallace over a Wilcoxon test. They talked about, yeah, there was no comment. And again, in ANOVA and t-tests, as everyone knows, you have to assume a homogeneity of variance, which they never talk about in these studies for some reason. And the confidence intervals in the data are quite wide. Okay, the results. They had 100 patients scheduled, 61 in the study, which means obviously a whole group people were excluded. So that the exclusion criteria was, was almost, sort of more than a third. But those who were excluded due to poor literacy skills, which feeds back to what we were saying about patients who aren't literate need to be informed in a better way. Anyway, at the end, they had 22 in the multimedia group, 18 in the verbal group, and 21 in the pamphlet group. They state no significant differences in age, education level, which I have no idea how they tested. It might have been school, yes or no. They had this abbreviated mental test and previous computer experience. And I looked at anxiety as well, which I thought was a nice little touch. The recall was tested at those 3 time points we mentioned previously, and in the end, they found that the multimedia presentation was better than everything, but multimedia and verbal consent were both improved in terms of recall at the 3 time points in the pamphlet group. So basically, handing someone a pamphlet and saying she'll be right is not good enough. And they also acknowledged that the variability could have been caused by the fact that they weren't sure how much surgeon registrar information was actually given to the patients pre-trial enrollment. Okay, so that's about it for this study. Essentially, the numbers were small, but it is a good pilot study. It does suggest that if we look at larger numbers across broader ranges and maybe with multimedia packages tailored to more patient groups, we might do better. What their data suggests is that you need to be quite selective if you do have a multimedia format in which person you allow to consider that to be informed, because I think that could be open up a whole new can of worms as far as medical legal things is concerned if you send the wrong patient to a presentation rather than actually seeing a doctor with an interpreter or other help is required. I thought one thing that would be really nice for us would be to do in an appropriate patient group would be just to not have to do informed consent in clinic. You could make clinics organised in such a fashion that all your needs came together and you put them through a knee multimedia presentation. There have been other studies that have shown Shaw et al. Looked at, I think, colonoscopy in 2001 and showed they had better retention then. They said often people were revisiting that people had better, people were able to revisit information with their format, so where the reinforcement yielded better results was there as well. One thing that I thought was that we can actually provided as part of a patient pack and put it in a media-friendly format. Obviously, there'll be things in terms of development, approval of information, whether or not we involve a body like the RACs, and integrating patient understanding, but you face that problem already with verbal consent, which is why people are looking at these avenues anyhow. So should we use multimedia consent? Even taking things cum grana salis from these guys, they did have above 90% across the multimedia group. I don't think it's going to replace having good rapport and having good doctor-patient relationships and actually engaging your patient. Because a lot of medical legal literature, I sort of leaned on some family that are involved as medical defense attorneys about this, and all their literature essentially says that the doctors who don't get sued are the ones who engage their patients and have a good relationship with them. And when patients are asked, why didn't you sue your doctor? It's like, well, he did everything he could. I trusted him. He talked to me about it and apologized. So you're never going to replace that with a computer program, but you are going to certainly make things potentially more efficient. And you could look at this in a bigger trial, or I'm sure that they'll happen down the track. Again, as a finishing note, there have been lots of studies that talk about informed consent being a myth, in that no one is ever truly informed. If your resident who is a medical practitioner, perhaps soon to be surgeon, is not informed, how can you possibly hope to truly inform a patient? There's an article in JBJS, British, 2001, I think, that looks at that, and there's also an article in Neurosurgery from '92 that also essentially they went not just saying, do you understand there's a risk of infection, but understand the significance of that. No patient could really go beyond sort of a cursory saying, yes, I may have loss of fixation, I may have infection, but they didn't actually understand what that would mean in terms of the deleterious effects in the longer term. So whether or not we're actually truly ever going to achieve informed consent, I don't know, but I think removing the surgeon at all and just having a program that has got a limited scope would probably make that problem worse. So at the end of the day, it's probably an adjunct rather than a replacement for a doctor, which makes me feel good as a doctor.